This is the third part of respiratory dysfunction. So we've moved to the throat area now, to our croup syndromes. Acute spasmodic laryngitis. This is what people are talking about when they say my baby had croup or my child had croup. It's usually kids under 3 or so, and it most often happens at night, and they're fine the rest of the time, which is this paroxysmal, meaning it comes and it goes. They get this terrible barky cough thing at night. It's inflammation in the throat. The best treatment is running that cool mist humidifier at night while the child's sleeping. If they do have an episode and that humidifier is not enough, then turning on the shower, making a really steamy bathroom and taking them in there. So just increasing the humidity. This is usually viral. It will usually run its course, and they usually look fine during the daytime when they're not having that cough. Just as an aside, the reason we recommend a cool mist humidifier is kids will burn themselves on hot mist humidifiers. For a toddler, it looks fun to go and play in the mist, and it's easy to pull it over on themselves and burn themselves. There are still some hot mist humidifiers sold out there, but they're not as safe as the cool mist. So moving on to tracheitis. You're going to see this at the hospital most often on kids who have global delays and a tracheostomy in place. Those are the kids we see it on at the hospital. The book says it happens in children younger than 3, but if you're delayed to the point where you're bedridden and you have a tracheostomy, you're at risk. Age really doesn't matter. So this has some features of all the others, croup and epiglottitis, similar to that laryngeotracheal bronchitis. Really what you have is very thick purulent secretions. And as I said, most of the time when we see this at the hospital, it's kids who have a tracheostomy. So what we're going to be doing is suctioning them. We're going to give oxygen and humidified oxygen to thin those secretions as much as possible. Antipyretics, if they're running a fever, antibiotics, because this is usually bacterial, and then the book says that may require intubation, but most of the time when you see it, it's on the kids who have tracheostomies because they don't have the nose to block out germs from getting directly down there into the trachea. That's why they're at risk. And so we're going to be suctioning them. Suctioning is kind of a two-edged sword, right? The more you suction, the more secretions you make, the more suctioning you require. So we're going to really rely on the families. They know their child. They know what is just a little bit of secretion that they can manage and what is not. And if we can suction just the tip of that trach tube and not go deep, that's what we're going to do. If they can cough it up to the tip, we're going to just suction the tip to take it out. We really want to minimize deep suctioning. And you're going to see at Children's Hospital, anybody with a trach, we have taped it on the wall at the head of the bed. It says how deep to suction in centimeters, and our tubes, our suction tubes all have centimeters marked on them. We are suctioning just to the tip of the trach tube. We really don't want to go down and irritate the tissue in the trachea and make increased secretions. So moving on down to the lower airways, this is called the reactive part of the airway. If you see a child who's diagnosed with reactive airway disease, it means it's down in the lower airways. That's really our name for asthma when we don't want to use the term asthma. Asthma is considered a chronic disease, and we don't want to label somebody as asthmatic unless they've had several bouts of it, and now we say, yes, this is a chronic thing that we need to be monitoring. So if you see reactive airway disease, that's asthma-like, but we don't want to call them an asthmatic yet. So it's down in the bronchi and the bronchioles. We get constriction down there. In the lungs, part of the problem is the cartilaginous support of the lungs is not fully developed till adolescence. So that's why we do see things like bronchiolitis more in children, and that's where we're going. So bronchiolitis, our biggest culprit, is the virus RSV. And this is what the hospital is full of every winter. This is why Children's is so busy in the winter. It's infants with RSV. So the pathophysiology, the cells of the mucosis in the bronchioles swell and they secrete extra secretion, so the space, the lumen, is smaller, and now it has more mucus in it. So air gets trapped. Air trapping also occurs in asthma. You breathe in a lot, you breathe out just a little. You breathe in a lot, you breathe out just a little. And your lungs can do that. They keep getting a little more full and a little more full and a little more full until there's no more room to breathe in. And then you go into a respiratory arrest very quickly. So we want to catch it earlier than that, obviously. We're diagnosing RSV with a nasal pharyngeal swab. So you put a swab down each nares and send that to the lab for viral testing. The main treatment is oxygen. These are the kids, they are sick. And these kids can go into a respiratory arrest and die. And the main thing we're treating them with is oxygen because it's virus. It will run its course. We're just supporting them and keeping their airway open in the meantime. We want to keep them hydrated. Most of these are infants, and you can't breathe and eat at the same time. Breathing takes precedence over that. So we're going to keep them hydrated. If they're able to do that by eating, fine. If they can't, we're going to do that with IVs or, anyway, whatever we need to do, we're going to keep them hydrated. There is an immunization they've developed, but it's only used on high-risk infants right now, and it's not very long, the immune effect it gives. So it's certainly not lifelong. It's not even years long. I said the main treatment is oxygen, and the way we give the oxygen is starting to be high-flow nasal cannula. Some kids are okay with just a little oxygen by nasal cannula, but most will need this high flow. High flow is not anything like regular nasal cannula. It blows hard enough to keep positive airway pressure. It's much more like CPAP. It is one step below intubation. So it is blowing constantly, keeping those airways blown open. We don't ever take it off. It's designed where it's got a little fold right here, so you can take this nares out, suction it, then put it back, and then let them recover, and then do the same thing on the other side. So you don't take it off, you kind of fold it in half. It can be, the physician will order the liter flow as well as the percent of oxygen. So we're blowing the airways, the small airways in the alveoli open. Once those are open, we may not need a lot of extra oxygen for gas exchange. So they may take them down, start at 100%, bring them down to 70, 30%, maybe even room air, but still be blowing with that high flow. So that's just something to think about. I know on the paperwork I often see O2 80%, or that would be maybe a cardiac kid, we're okay with that, or O2 92%. I think you mean O2 saturation of the blood, because remember, we can do things like with this high flow where we're not necessarily always using 100% oxygen. So just be careful as you're writing that you're clear what if you're talking about the oxygen we're delivering or the oxygen saturation of the blood. So pneumonia. Pneumonia is a solid area of stuff in the lungs. It can be caused by most anything: virus, bacteria, mycoplasm, a foreign body, aspiration of something. And what we're going to see really depends on the age and how big the area of pneumonia is, right? Babies just have less lung field, so they're going to look worse with the pneumonia. Sometimes you get kind of that systemic illness where they look acutely ill, they're always usually going to have a cough that sounds really deep because they're trying to cough out of the deep parts of the lung. So my analogy for lungs is, think of your lungs like a Disneyland balloon, right? We've got Mickey's head on the inside and another balloon on the outside. Pneumonia is inside Mickey's head. There is nothing we can really do in here but give antibiotics to kill the germs, give you lots of hydration to thin the secretions until you turn, cough, and deep breathe. Pleural effusion is between the two. It's outside of Mickey's head, but inside the other balloon. So it's between the lung and the pleural sac. Now, both of them can stop one of the Mickey's ear from being expanded. So it can cause atelectasis. If it's inside, if it's pneumonia, it's blocking the air from getting out here and expanding that ear. If it's a pleural effusion, empyema and pleural effusion are basically the same thing. It's just the difference between how thick the secretions out here are. But if there's something out here pushing on that ear, preventing it from expanding, it's going to look the same. You get atelectasis either way. The question is, from what? And if it's out here, we're going to put in a chest tube. A chest tube can drain out serous fluid, purulent fluid, air if it's a pneumothorax, blood if it's a hemothorax, but it's not going to do anything if there's a blockage inside here. This, we're going to give you antibiotics, hydration, until you turn, cough, and deep breathe. How do we tell a baby to deep breathe, you may ask? Well, blowing bubbles makes you take a big breath beforehand. Blowing a pinwheel. We don't light candles at the hospital, but holding up a finger if it's a little older child and telling them to pretend to blow out birthday candles. All of those things will make them deep breathe. We do have incentive spirometers for kids, but bubbles usually work better. So that's pneumonia, and I wanted to kind of compare it to pleural effusion for you. Pertussis. This is also called whooping cough. This is caused by a bacteria, so we are going to treat it with an antibiotic to kill the bacteria, but even with killing that bacteria, it takes a while for the kids to recover from this. We have an epidemic right now going on in Fresno County with pertussis. We're improving. We're kind of past the peak, but we still are seeing a lot of cases. These kids are just plain scary to see. They cough and cough and cough and cough and cough and cough and cough till they turn red, purple, and then they take a little tiny inadequate breath and they start coughing again. That's the whooping cough name because it's kind of a whooping sound when they take a breath. It is not an adequate breath. So in the hospital, we're going to blow oxygen past their face. So when they take that little breath, we want as much oxygen as possible to go in. This is contagious, and the big problem is we give you a vaccine for it, but it does not give lifelong immunity. The immunity wears off. You get a booster when you start school, which wears off around junior high. Once we started having an epidemic, we started giving another booster at junior high, but that's going to wear off in early adulthood about the time you're having children. And if you're becoming a grandparent, you may have not had a booster in decades. So what you think is just a bad cold that's taking a long time to get over can kill an infant. So we're really trying to get everyone having children or around children, whether you're a grandparent, an auntie, whatever, to get a DPT. We used to just give DT, diphtheria and tetanus, to adults, and now we're giving them with that pertussis, not for their protection, but for infants that they may be around. And I think this is a good spot to stop.